Okay. Hi there. My name is Blake. I'm going to go ahead and do a presentation on hip dislocations, Miss City. So here we go. Last one I recorded actually went over the max time limit, so I'm going to try to keep this in between 12 minutes because the max time is 15. But basically, I'm going to do hip dislocations. So uh, basically, as you can see on the left here, this is Bo Jackson. Bo Jackson was a famous football player. Actually, he played baseball too, but hands down, probably would have been a Hall of Famer if a hip dislocation didn't put him out of action. As you can see here, um, it's kind of a weird. It was a very weird injury, but this is basically this is one of the more famous. When we talk about hip dislocations, more famous injuries that we can kind of come around when it comes to an athlete that just never was the same. So basically, when the hip dislocates, it's basically when the hip dislocates or dislodges from the acetibular rim. Much force has to be applied in order for such events to occur, and it's very common for athletes to never be the same quite after an injury like this, in which hip pain is very prevalent after such a trauma. So basically, a lot of times what you'll see is that the athletes are not able to use the quadriceps and different muscles within the leg the same because of the traumatic damage applied to that ball and socket joint. So I'm just going to give some quick statistics. Age, the population, what sports and activities have the highest rate. So one study conducted by a single surgeon through 2006 and 2000 and 2006 on 16 professional athletes had such injuries. So if you think about a 6-year span, 16 is pretty small compared to even 1 year. The NFL had, I want to say, 50 plus some ACL injuries. So that's kind of just putting that in perspective. 12 were male, 2 were females. This was a little shocking to me because there is evidence that females do have a higher prevalence of um, uh, hip dislocations because of that Q angle with the knee and hips due to kind of biological factors. So, but it also wouldn't surprise me 12 males just because of the males usually are generally a little stronger when it comes to forces being applied. So many were not able to pursue professional aspirations or continue professional careers after this because I believe this was conducted within a kind of a feeder league organization, if you could say, so like semi-pro. It contributes to 45% of all hip replacements, 10,000 to 20,000 reported cases annually within the U.S., so very small. So it's very rare, and it's rare to very rare in the younger population. More common in the elderly, so the joke kind of is, sometimes, grandma busted her hip. This is actually sometimes a true phenomenon, is where as you get older, things start to break down a little more, but definitely when you become geriatric a little bit, your hips are not able to sometimes apply the amount of force, or take or sustain that amount of force that you were able to apply when you were younger. It's also kind of more common with people with cerebral palsy. So if you think about biomechanical kinese, um, when you have an awkward walking gait or a gait, a lot of times people will have um, not be able to sustain the forces within the hip region, so causing them to have things like hip dislocations. So anatomy, you got a hip and ball and socket joint. So um, basically, that's where, if you think ball and socket, so you got the ball here, and then you got a socket. It's kind of just like a little. It's basically where our shoulders and hips and kind of hold stuff together, or the hip and different hips and bones. Consists of the head of the femur. Pelvis cradle holds the acetibular where the ball sits, and ball consists of articular cartilage, which allows for mobility, so a lower sense of friction. But the acetibular also consists of the fibrocartilage called the labrum, which, if you think, when you got two or types of cartilage on each other, that's going to be it's going to allow for less friction. So that allows us abduction, adduction, internal rotation, external rotation. It's going to allow us to do all those things. So when you think of hip mobility, a lot of times it's how well our hip is able to work around those muscles and things like that. As you can see here, these are the most important muscles of the hip when it comes to hip dislocations. So you got the iliopsoas, pectineus, abductor longus. This is the anterior view, by the way. And then the rectus femoris, and then tensor fasciae latae. Oh. So and all those play that key role in hip mobility and motions like abduction, adduction, internal rotation, external rotation, even flexion, flexion of the hip joint, extension, things like that. So the anatomy continued. So injury is also known as a femoral cibular impingement. Traumatic forces are applied along to the long axis of the femur. The knee is usually flexed with this, so along with knee flexion, the thigh will usually be rotated internally and adducted, so toward the midline. So as you can see here, that kind of gives a good little pictorial view of what we're working with here. And then most dislocations will occur posteriorly to the acetium. On rare occasions, it can dislocate anteriorly. So as you can see here, it's a little more like the knees pointed outwards. It's minimally flexed also, and yeah, externally rotated. Okay, let me see. Next one, so we got genetic on ethnic factors. It can be genetic and ethnic factors degenerate at birth. So Molzer et al. Suggests there may be a significance or be a difference in acetibular morphology and femoral bone response to athletic loads in 445 male soccer players of different ethnicities. So he took a study of different ethnicities and noticed that there was some differences within them. But with this study, he did notice though there might have been some skewed data with too many different ethnicities. So I think want to say like in this league there was like almost 50% Arabic males. So he wasn't able to put a real number or percent on it, but there is ethnic differences in it. Affects 1 to 5 babies in China out of 1,000. Very high genetic factor. A lot more actually than ethnicity. And then basically where at birth in the breech position, the baby will sometimes have the deformation of the bones because they're just sitting differently in the mom's womb. So the biggest thing I took away with with genetic factors is there is a gene called the GDF5, which is a cartilage-derived morphotic protein, which is important to the growth factor in regulating cartilage growth and differentiation. This was the most heavily researched and prevalent literature out there when it comes to what's causing hip dysplasia, different cell growth, and things like that within the hip. There are more factors coming out though as research continues, and it's more common actually within girls and Native Americans and Laplanders. So Laplanders, by the way, if you don't know what that is, it's literally an island in northern Europe that it consists of different ethnic northern, so like Scandinavians, Danish, Norwegian, Sweden, and they're all kind of compiled on an island. So here we have the mechanism of injury. So it's a high energy mechanism is needed. Thus, lots of force is going to be needed to require such an injury. It's seen many times within car accidents. The posterior dislocations can be due to it's due to the hip abducted, leading to posterior force vectors. So kind of I talked about that before within the anatomy of the injury. Many times this will be internally rotated, in which causes that posterior force to really kind of be applied there. Anterior dislocations, they're a little more rare. It's due to the hips being abducted and externally rotated, but much of hip dislocations are still quite unknown, as the literature is kind of still reviewing and understanding the mechanism of injury. But genetic and ethnic factors are a very key role in this type of injury. Genetics can also impact acetibular dysplasia, joint laxity, or both. So even with people with ACLs, they might have like, for me, I have a lot of joint laxity in my knees. I might also have joint laxity within the hips, and that's just partly due to genetics. Here I have a little video. This will kind of even go through the different immediate care scenarios. So this is Wayne State versus Nebraska Kearney. So as you can see here, twisted it, internally rotated.
All-conference free safety, hitting Schultz hard, and Schultz is slow to get up. And he is holding his knee, and that is not a good sign, Larry. He is in a lot of pain. First carry of the season.
And as you can see here, they're kind of actually doing the immediate reduction necessary.
Than you would have anticipated this season. Johnson was the starting quarterback for most of the last.
Very, very tough. That was one of those injuries too that you sometimes think it's a knee injury, but it's actually he just had a hip dislocation there. Very kind of neat. Very good by the athletic trainer doing that right away. So as you can we'll get into immediate care. So first things first is reduction. So the hip should be put back into place, whether that be on the field, sideline, or emergency room. The sooner the better for an injury like this, as it reduces inflammation, things like that. Blood, it'll get the blood flow back to the spot, because some literature shows that when the blood flow is kind of suppressed, that a lot of times the injury will be a little more severe. So muscle contractures can complicate the reduction process. So this is where the muscles basically are stiff yet. You'll have the person there, kind of as you see, is still very tense, so it can be very hard to sometimes do that right away, but it's kind of necessary. After such injuries, most athletes will go through anterior posterior pelvis cross table plane radiographs. So that's basically so when they get them to the emergency room, that's the first thing they're going to do. But they'll also take magnetic or MRIs and see the different pathologies of the injury. So there is, with hip dislocations, there is probably a good chance of surgery. First thing they'll do is hip arthroscopy. So basically that's what it's going to do, is going to allow the doctor to make a small incision within your hip by cutting through here, kind of just a little on your little bit of your pelvic cradle, and it's just going to allow the doctor to kind of see the hip joint and cartilage and femoral head and all that stuff to see what they're dealing with. Patients may have chondral defects of the femoral head, intra-articular loose fragments, lesions of the femoral head, neck, which osteoplasty is needed to help prevent later impingement. So that's kind of where they're going to have to repair some of the articular cartilage, the labrum, things like that. Many times the capsule within the acetibular is needed for repair. So that's kind of just going back on that they're going to have to sometimes resuture some of the articular cartilage within that cibulum. So rehabilitation and return to play. So first things first, this is kind of the plan of attack when it comes to injuries like this, but immobilization for 2 weeks. People that will have these surgeries, sometimes it does actually too result in a complete hip replacement. As that becomes a little more common, and as technology grows, that's something that's becoming more complacent or common stream. So first 2 weeks, bed rest, very minimal movement compared to other injuries where they might get you going really fast. This is something that really needs to heal. So then after that, you'll have a use of crutch for a month or even longer, depending on the severity of the injury. After the crutches, you'll have progressive range of motion exercises. So this is going to be things like riding on a bike, probably for like 20 minutes, doing elevation, glute elevations, even flexion of the knee a little bit, things like that, to kind of get the range of motion back. You're not going to probably do internal and external rotation right away, as this is you need to kind of do the base movements first, like elevation and depression and things like that. Mostly day one rehabilitation will involve non-resistance biking, and that's basically just to get the motion going. So no resistance, no anything. Then you're going to go to an open chain, closed chain exercises. Next step will then be running, cutting, and then return to sport. And this could probably take up to a year. a year and a half or so.